So the next time you drive down a major roadway or highway, simply look, and you'll likely see signs or billboards advertising the services of a health system or hospital, or increasingly emergency services, pointing out things like efficiency and quicker care and faster care, all obviously in an attempt to actually attract paying patients. But there's a story behind this that I think it's important for you to understand. That emergency services and emergency care has not just become an integral part of modern health care, but it's become truly the safety net for a health system that's in need of repair. With emergency department visits actually growing to over 140 million visits a year, hospitals, especially our safety net hospitals, are at a breaking point, and costs are mounting. So one may ask the question, how did we get here? How did our safety net system actually evolve to this point? Well, we have to go back to more than 50 years ago to understand what happened. And this is the birth of emergency medicine as a specialty. So you see, in 1961, a group of physicians, family physicians to be exact, decided that they were going to leave their practices, their well-developed primary care practices, to fill a growing need in the healthcare system at the time. And that was to fulfill the need to provide after-hours care reliably during that period of time. So, in the basement of a hospital in Alexandria, Virginia, they opened up a one-room, two-bed emergency care practice, and this was called the Alexandria Plan. And this plan actually served as one of the blueprints for what emergency medicine has become today. A phenomenon that's actually grown from a neglected mission in the basement of a hospital to one of the most sophisticated and essential offerings in healthcare today, but a very costly safety net for health systems failures. Now, pivotal to the growth of emergency medicine was a law that was passed in 1986 called EMTALA, Emergency Medicine Treatment and Active Labor Act. Now, believe it or not, before 1986, there were problems in the healthcare system, big problems. Because you see, in parts of our country, patients, critically ill patients, even patients who were dying, were being turned away from hospital after hospital because of one problem: they couldn't afford to pay. And what was really interesting about this was that this law, EMTALA, essentially focused on ensuring that these hospitals did not pursue the discriminatory practice of not caring for patients who could not afford the high cost of health care, of emergency care, of treating and manage those conditions. Now, what's interesting about this is hospitals before 1986 actually did not have the legal obligation to care for patients. And so what happened was that this law, EMTALA, essentially also served as a safety net for patients who were on Medicaid or patients who were in government insurance. But in fact, what it did was it protected everyone and anyone who wanted to enter the emergency care system for care. EMTALA, this law, essentially became national healthcare policy for those who were uninsured and underinsured. This was a mandate. It was a mandate that's lasted for more than 30 years. This was a mandate that essentially did one thing. It diminished access barriers to healthcare through emergency medicine more than in any other part of the healthcare system. So as a result of this, emergency departments today serve as a safety net for society's most vulnerable, including minority communities and the poor. But there were challenges that actually lay ahead, significant ones, because after 1986, emergency department visits continued to escalate, perhaps because access to other parts of the healthcare system could not keep pace and were virtually closed or inaccessible to those most vulnerable. As a matter of fact, emergency department visits grew faster than the US population. Fact, between 1997 and 2009, US population grew by 12%. But during that period of time, emergency department visits grew by 43%. So make no mistake that emergency departments, especially at our safety net hospitals, are crowded. And the specter of more uninsured or underinsured entering our system, in addition to the aging population, is a prescription for emergency department visits increasing throughout the United States. But is this really the direction we want to go? An ever-expanding safety net system of uncoordinated care, complicated by inconsistent information sharing, duplication of services, and escalating costs. In truth, this law, EMTALA, was a victory for patients and was a victory for some form of access to care. But the question is, was this access truly sufficient? Perhaps we needed to pay attention to the fact that preventative care or long-term care or care based upon relationships was important. Perhaps some emergency department visits could be prevented in this way. Because you see, it is wrong to force patients to enter the emergency department system for care when that care could have been avoided or could have been perhaps provided in a less resource-intense, more connected, less costly environment. So you see, in emergency medicine, you have to get it right the first time, and you have to get it quickly. Oftentimes with insufficient information, and most of the time without a benefit of a relationship with the patient. So this is precisely why, in this fragmented system of care, that I have to look very carefully at my practice, knowing that I may actually have to order one more test, or perhaps admit to the hospital one more time, simply because I may not have a choice when our health system fails. And you may not see that, but I see that in the emergency department with increasing cascades of patients entering the safety net health system for the care that they cannot receive elsewhere. So while our healthcare system truly bristles with the best of technology and gleaming infrastructure and leads the world in advancement in science and discovery and medicine, you need only look under the hood to find that we're failing to meet the basic needs of society. And what do I mean by that? Well, let me explain. Of the 13 most developed countries in the world, the US ranks the lowest in life expectancy, the highest in infant mortality, and the highest in obesity rates. When you control for the size of the economy, comparatively speaking, the US actually spends the most in healthcare and the least in social spending. And these are just but a few indicators that point that our health system may be in jeopardy. Here are some more facts. 1/2 of patients that actually enter the emergency department system for care are either completely uninsured or maybe underinsured under Medicaid. 1/4 of acute care visits in this entire country, and virtually all such visits that are after hours or on weekends, are seen in emergency departments. Of all of the uninsured visits for acute care in this country, 1/2 are seen in emergency departments by physicians like me. But the emergency department is not just a place for the uninsured or the underinsured, because studies have shown that even those with insurance, 1/3 of them actually access the emergency department for care because they could not actually get care elsewhere, because elsewhere was not available. So you see, access to care to the emergency care system is virtually without any barriers compared to the rest of the healthcare system. And we need to understand that. We need to debate this. We need to discuss this. We need to repair this broken part of a healthcare system. People access the healthcare system through the only avenues that are available to them. And so in our society, 911 for millions of people have essentially become access to care. So we have to think about this a little bit. The rate of rise of emergency department visits and the increasing burden in our safety net system is going to happen, and we have to think about whether or not this is truly sustainable. So, how can we actually slow the cycle of flawed and vicious fragmented care and reliance on our burdened healthcare system? Well, a colleague of mine actually wrote in a recent paper that fear and uncertainty is what most often drives patients to seek care. Fear of the course and the consequence of disease, and the need for insurance, and the need for information. So what's happening in our healthcare system is actually exciting because people are beginning to really innovate around this. One of the things you're probably seeing today is a proliferation of freestanding emergency departments and urgent care centers and clinics in retail pharmacies and even department stores trying to meet this need. But here's what's happening in innovation in access to care. Hospitals and organizations, for instance, are looking at things like extending primary care hours or even extending specialty care clinic hours. Or how about telehealth, where cellular technology and Wi-Fi technology can be used to connect a patient to a provider, and a healthcare transaction can actually occur without an in-person visit. Now here at UF, we actually have an example of an after-hours clinic, the UF Orthopedics and Sports Medicine Institute, which a couple of years ago began to offer extended hours both during the week and also on the weekends. And the impact that has had is that emergency department visits for simple, uncomplicated orthopedic complaints and injuries have dramatically decreased. What about health information technology? Well, we must decrease the barriers to meaningfully share health information across hospitals and across health systems in our region while maintaining the safety of patient information. But why should we be doing this? So we can actually reduce duplication of services, so we could reduce costs, reduce unnecessary testing, and perhaps even reduce harm. Perhaps we should develop systems that allow patients to actually own their own health records so they could actually freely distribute it when necessary. Hospitals and organizations need to look at their own neighborhoods, their own populations, to really look at unmet needs. So we're doing some of this in emergency medicine, for instance. And we've done research that actually is focused on public transportation policy and finding that even that can impact the numbers of patients who actually go to the emergency department with potentially avoidable visits and even potentially avoidable hospital admissions. Primary care redesign is actually happening everywhere. So instead of fixed appointments during weekdays, you actually have open access. There is experimentation with what's called direct care, where folks are actually bypassing insurance companies and paying physicians a very small fee, like a gym membership, to receive basic health care. What about home visits by the primary care workforce? It used to happen decades ago. How about paramedicine, where paramedics are actually visiting the homes of patients who've just been discharged from the hospital to ensure that they're safe and they understand their healthcare needs? You see, we have to innovate around primary care. It's not just about expanding the primary care workforce. We must innovate. And these innovations, I think, become the future of improving healthcare in this country. But I want to return to one particular issue I mentioned, and that was EMTALA, this mandate that was signed into law more than 30 years ago. This was a mandate that we really could learn from, a mandate in healthcare. It had an unintended consequence, obviously, because it helped to fuel the rise of emergency department visits across the country. But this is a mandate that actually worked quietly in the background, ensuring access to care for those most vulnerable, but also ensuring access for those who have insurance who could not find timely care elsewhere. EMTALA is an example of a mandate that has demonstrated that mandates actually can work in our healthcare system, even though in this particular case it wasn't perfect because it created a one-way street on the health system's safety net. But maybe we should rethink this. Maybe it shouldn't be just assuring access to the emergency care and high-cost care. Maybe access to the very basic of health needs should be assured, regardless of your ability to pay, regardless of your socio or economic background, regardless of your cultural origins, regardless of your zip code. Perhaps we need to invest in, rather than abandon, the idea that long-term and trusting relationships between patients and physicians should be the cornerstone of good health policy, empowering patients, advancing patient-centered care, and yes, improving outcomes. Perhaps we need to rethink the fact that our health system safety net only has a one-way street. So in this most developed country in the world, I have seen example after example of failures in our healthcare system. I took care of that middle-aged man who would not have had that devastating stroke if he actually had timely and effective access to care and could afford the medicines that would have controlled his blood pressure. I personally grieved with that family of that woman, that wife, that mother, who I tried to resuscitate and I couldn't, because she actually died on the way to the hospital from asthma, a completely preventable disease. Why? Because she didn't have access to primary care or access to the medicines that could have saved her life. I've seen, like my colleagues across the rest of the country, example after example of failures in the healthcare system, but there is good news. And the good news is that we are seeing innovations in our healthcare system. People are thinking about access to care. People are thinking about how we can truly improve care in America. And so we have to grab this opportunity and truly rethink how we approach healthcare in America. Thank you.